This is Kidney Cancer News.
This month in Kidney Cancer News, a look at what's on the horizon for the treatment of kidney cancer. Bill Breaux, Kidney Cancer Association CEO, has this update.
Thanks, Carrie. We scan global news resources to bring you the latest items of interest to families dealing with renal cancers.
One of the questions sometimes asked by patients and their families concerns occupational hazards related to kidney cancer. From Yahoo News, Yukon firefighters win job-related health benefits. The CBC.ca reports Yukon firefighters have secured benefits if they suffer from heart attacks or certain types of cancer considered to be job-related. Amendments to the Workers' Compensation Act to include coverage for firefighters passed third reading Thursday in the Yukon legislature. Starting on the 1st of July, the new law will apply to all of the nearly 400 full-time, part-time, volunteer, and wildland firefighters in the Yukon. Heart attacks suffered within 24 hours of fighting a fire will be presumed to be job-related, as will at least 10 cancers that regularly haunt the firefighting profession, including lung, brain, and kidney cancer. If at any time after June 30th, 2011, a person who is or has been a firefighter is diagnosed for the first time with a listed disease, that disease is presumed to be a work-related injury unless there's evidence to the contrary. Firefighters are often exposed to toxic smoke from burning building materials, household contents, and plastics. As a result, they face an increased risk of developing cancer. Firefighters have been pushing for these changes for a number of years. In news from the United Kingdom, a £5 million grant has been given to an international consortium of scientists led by the Cancer Research UK's London Research Institute to further studies into personalized kidney cancer treatment. The money was granted by the European Union so that the team can identify gene targets for personalized treatment. In order to identify which genes regulate cancer cell growth in a low oxygen environment, the researchers will screen the entire gene set in kidney cancer patients. This will allow them to gain a better understanding of how cancer cells respond to drugs blocking growth of blood vessels to tumors. Dr. Charles Swanton, head of Translational Cancer Therapeutics, is leading the scientific section of the consortium and says this exciting opportunity means clinicians and scientists across several European centers of excellence can work together to find ways to match kidney cancer patients with the treatments that will work best for them. Ocean Road Cancer Institute in Dar es Salaam receives more than 500 reports involving childhood cancer cases in the country each year. Experts say that figure is underestimated. Only 20% of patients have direct access to the Cancer Institute due to various reasons, including financial constraints and cultural factors. A study done by Trish Scanlon and Tawid Nagoma of the International Network for Cancer Treatment and Research in Tanzania indicates that in 2005, about 150 children were screened, and by 2009, that figure had climbed to over 300. Burkitt's lymphoma is said to be the most common in Tanzania and other Central African countries where malaria is endemic. Other common cancers are retinoblastoma, eye cancer, and nephroblastoma, kidney cancer, Wilms tumor, acute leukemia, and Kaposi's sarcoma. Few childhood cancers which are caused by environmental factors can be prevented. For example, Kaposi's sarcoma is associated with HIV/AIDS, so prevention of mother-to-child transmission of HIV can reduce the prevalence of childhood Kaposi's sarcoma. Despite efforts done by the Institute, patients have been complaining about a shortage of beds since 2 or 3 children share a single bed. The American Association for Cancer Research will recognize 27 recipients of the AACR Thomas J. Bartos Science Education Award for undergraduate students at the AACR 102nd Annual Meeting held in Florida from April 2nd to the 6th. The primary purpose of the American Association for Cancer Research Science Education Award for undergraduate students is to inspire science students in the undergraduate level to enter the field of cancer research. Among those receiving awards are one specifically dedicated to renal cell carcinoma. Xiaoying Sarah Zhu of University of Toronto will be studying caveolin-1, a protein that promotes cell proliferation and tumor growth in kidney cancer. From the publication Urologic Oncology, an article, Is There a Role for Partial Nephrectomy in Patients with Metastatic Renal Cell Carcinoma? The incidence of metastatic disease in patients with kidney cancer correlates with tumor size. This study sought to determine the incidence of metastatic disease by tumor size and the utilization and impact of nephron-sparing surgery on survival in those with metastatic disease. 8,498 patients had metastatic disease, 4% of patients with tumors less than 2 centimeters, 5% with tumors between 2 and 3 centimeters, all presenting with metastatic disease. 2,950 patients with metastatic disease underwent surgery, either radical or partial nephrectomy. 70 patients, or 2% of those undergoing surgery, had a partial nephrectomy. Those who underwent partial nephrectomy were less likely to die of kidney cancer than those who underwent radical nephrectomy. In conclusion, albeit small, the risk of metastases in patients with small kidney tumors is distinct and should be considered in management discussions. Partial nephrectomy, when able to be done, should be utilized in the setting of metastatic disease. The Kidney Cancer Association, based in suburban Chicago, through its membership, has participated for several years in the Cancer Genome Atlas. We turn now to the National Cancer Institute for a brief discussion of the genetic basis of cancer.
The building blocks of DNA are the fundamentals of how a cell works. In the normal cell, the DNA makes everything happen that should happen. In the cell that has cancer properties, the DNA makes the odd things about a cancer cell happen. So if we can identify every single DNA base and figure out where each one is and where it should be, and what's changed about that in cancer, then we can figure out what's gone wrong at the functional level.
We're made up of billions of cells, trillions of cells, and each one of those cells has, in principle, the same genetic code. It's the code that we were created with as a single fertilized egg, and that determines who we are. Every single cell carries that genetic information with it. But if you look at our bodies, we are composed of very different cell types. And if you look at the skin versus, say, a liver cell, they have exactly the same DNA sequence, or for the most part. There may be an occasional mutation that's irrelevant, but for the most part, they're identical genetically, but yet they have very different phenotypes. They have very different appearance. So the cell in a skin cell looks very different from a liver cell. And so the question is, how can exactly the same DNA code give very different appearances, function, behavior of cells?
Most of human DNA is constant between individuals. So if I look at my DNA sequence and yours, it's virtually identical. There are certain sites at which it will differ. A lot of these sites have absolutely no effect at all. They just happened by random chance. A lot of the times, however, a DNA site, a given position, can be changed in some way. So an A can change to a G, or a whole chunk of A, G, C's, and T's could be deleted or missing. In cancer, we look for particular cases where this kind of change occurs in an important gene or an important pathway that might indicate that changing that gene is what led to that cell becoming a cancer cell.
We know that cancer is a multi-step process, and cancers can be broken in very different points in their sort of in the normal mechanism of how cells live and how cells function. DNA tells us a lot about where the broken parts are, and that's critical for targeting our fixes. For example, if your car's making a rumbling in the front, you need to know if it's in the engine or in the transmission. And that's sort of what we don't know currently. Is we know that these cells are broken in some way, but we're not always able to tell where the break is so that we can target it with a therapy.
Ronald M. Bukowski, M.D., is chairman of the board of directors of the Kidney Cancer Association and is an internationally recognized expert in the treatment of this disease. Recently, we spoke with Dr. Bukowski by telephone about the importance of clinical research. In subsequent broadcasts, we'll talk about specific clinical trials.
What are some of the key advantages for patients of the newer therapies for treating advanced kidney cancer?
That's a very important point. The treatments have changed considerably in the past 5 to 10 years, and I think one of the big advantages for patients overall is accessibility, because now when you look at who can take these treatments for kidney cancer, it's the vast majority of patients, no matter where they live and where they're located, because physicians all over the United States really have learned to apply these because they're easily administered. They're oral treatments for the most part. Their side effects, although they occur, certainly are manageable. And importantly, these are effective in many, many patients. Effective means that they control the progression of the tumors. They can certainly shrink tumors, and patients overall have done better with these. When I look back at the field the way it was about 10 years ago for folks with kidney cancer and compared to how they do now, it's considerably different. They're doing better. They have much more productive lives with these treatments, and they've sort of turned into chronic treatments. Side effects, yes, but they're controllable. I mean, you can control them by altering the dose of the medications, by delaying treatments, altering the schedules, and so there are a lot of options here for patients. So there are many advantages to the newer treatments.
Patients are always naturally curious about what's on the horizon. Can you tell us what's in the pipeline for treating kidney cancer?
Thankfully, there are many new options that are being developed for the treatment of this disease. So it's not just the 6 approved medications or regimens that we have, but newer ones that are always being looked at. And I think the way to think about them is, well, take a look at the standard medicines like Sutent and pazopanib and Orvotriet, that is, and Nexavar. These all are useful medications, but they're sort of newer versions of these coming along very shortly. Drugs like axitinib and drugs like cabazanib, all of them have very similar mechanisms of action, but perhaps they're better. Perhaps they have less side effects, and I think axitinib probably will be the first one that the patients will have access to. Drugs like everolimus and temsirolimus, these are what are called mTOR inhibitors, and there are newer versions of these in development that may well be more effective and may have better scope of activity. We shouldn't lose sight of the fact that probably immunotherapy, which was sort of the mainstay for treatment of kidney cancer in the 1990s and early part of this decade, is making a resurgence, because there certainly is a new class of drugs called the immunomodulatory antibodies. And these are really exciting. These are sort of proof of concept that indeed the immune response is not effective in many patients with advanced kidney cancer and needs to be improved. And drugs such as epilimumab from Bristol Myers Squibb and another antibody that inhibits a similar type of molecule called PD-1 are under development. Epilimumab is really going to be approved here for melanoma probably as we speak. The others in development. And vaccines are making a resurgence. There are certainly some interest in developing new vaccines. So these are these are really exciting, and finding alternate pathways. I think the important issue here is we're not standing still. We're defining newer treatments, and there may well be totally different approaches that will come out of some of the scientific discoveries that have been made in the past 5 years. So it remains an exciting area, and patients should really feel that there's optimism in this area and the likelihood of having even new and better treatments in the foreseeable future.
I think that some people may not be aware that these new therapeutics wouldn't exist were it not for the clinical trials process. Why should patients discuss participation in a clinical trial with the doctor?
That is very critical, because if we're going to make progress and continued improvements in the way this disease is treated, the clinical trial is sort of the mainstay. I know when I was working at the Cleveland Clinic and treated patients there, I had really the sense that the clinical trial was the most important mechanism to help our patients. I thought that it was the way to allow them to sort of have access to cutting-edge therapies, new treatments, and I really believe that the clinical trial, the way the medications were administered or the mechanisms involved in developing clinical trials really were optimal for patients in terms of treatment. Now, that's not to say that everybody has to be in a clinical study, no, but I think we shouldn't lose sight of how we make the advances in this disease and the fact that the clinical trial remains essential if we're going to continue to move the field ahead. We can't lose sight of that. And one sort of ancillary point is, as a part of a clinical trial, sometimes there are some science-related projects that are conducted. This is called translational research, where we're trying to learn how the medications work or how the disease is behaving or why the disease is not responding. These are called translational studies, and these are crucial in our understanding of diseases like kidney cancer. And I think that the combination of clinical trials and translational research are really pivotal in terms of continuing the progress we have made. So clinical trials are very important and remain so as a part of the way to improve the outcomes for patients.
Are there advantages for patients who participate in clinical research?
I think so. I can't provide hard evidence that a patient in a clinical trial does better than an individual outside of a clinical trial. That's really a hard concept to test. But I think if we buy the fact that this is cutting-edge treatment, generally speaking, in a clinical trial, and that participants are followed very carefully by their physicians and nurses and teams, well, then I think it's clear that this is probably a way to proceed. The history of clinical trials in kidney cancer is an interesting one, because in the past 7 to 8 years, there have been well over 5,000 folks who have participated in these clinical studies, and they're the individuals who have really allowed the treatments that we now use to advance. And so, do patients do better in clinical trials? I think they certainly don't do worse, and I think that they certainly provide an important way for patients as a whole and doctors who treat patients with kidney cancer to move the field ahead. So I think advantages for the patient, yes. For society, yes. For the physicians interested in this disease, yes. And so it's sort of a no-lose proposition for the entire group interested in controlling this disease. So I'm a firm believer that the clinical trial really has been a significant way that has allowed us to approach and treat this disease.
Join us again next month for another edition of Kidney Cancer News. We'll bring you information from researchers in Europe who are working to unlock kidney cancer secrets. Until then, I'm Carrie Konosky, wishing you good health.
Join us again next month for another edition of Kidney Cancer News.